Good morning, good afternoon, and good evening, everyone, and welcome to our webinar titled An Integrated Understanding of Pressure and Flow, an Essential Partnership. This webinar has been sponsored by Transonic Systems and is produced in partnership with the American Physiological Society. So a big thank you to them for helping to make this event possible. Joining us today, we're very fortunate to have Dr. Fiona McBryde, a senior lecturer of physiology at the University of Auckland. Her presentation will discuss her research that focuses on the relationship between blood pressure and blood flow to understand organ perfusion in health and disease states. Fiona, take it away whenever you're ready.
Thanks, Sarah, for the introduction, and to the American Physiological Society for the invitation to give this seminar. As Sarah mentioned, I'm based from the University of Auckland in New Zealand. This isn't quite the view from my office window. There's a few concrete buildings in the way, but it's not a bad place to be. So the ultimate purpose of our circulatory system is to deliver an appropriate supply of oxygen and nutrients to every organ in our body, with the flow of blood to each organ being constantly adjusted to meet the individual metabolic needs of each tissue. And this all occurs against a backdrop of constantly varying blood pressure and cardiac output as we go about our daily lives. So how do we do this? So I want to start by just very briefly reminding the audience of probably something they studied back when they were an undergraduate student about the fundamental basis for our understanding of pressure and flow in the circulatory system. Sir Jean Poussuet, a French physicist and physiologist, in the mid-1800s experimentally derived and formulated Poussuet's law, which describes the non-turbulent flow of liquids, aka blood, through pipes of uniform section, in other words, our blood vessels. In vivo, the importance of vessel diameter, radius to the power of 4, means that vascular resistance is the key target of autoregulatory control. And this occurs by a number of different pathways and mechanisms, but the organ must also cope with fluctuations in the supply pressure or blood pressure. And today I'm going to focus a little more on this relationship between pressure and blood flow and organ perfusion. And I'm going to start by defining what we actually mean by the selfish brain, and then talk about some of our current research challenging the traditional concept of cerebral autoregulation, and finish by discussing these implications of these ideas to the clinically relevant situation of ischemic stroke. We can then move on to talk about some really recent work that we've been doing that's really exciting about the modulation of pressure and flow in the venous reservoir. So I want to start with a focus on the organ in our body that arguably has the most skin in the game. So although our brain only accounts for 2% of our body weight, it receives about 15% of cardiac output and consumes about 20% of the available blood oxygen at rest. What do I mean by selfish? I'm not really talking about sharing toys. So we believe that the brain's high metabolic activity and lack of energy reserves causes the brain to put an utmost priority on maintaining an uninterrupted blood supply. So if this blood supply becomes threatened, then we speculate that the selfish brain may induce systemic hypertension or high blood pressure in order to help protect that cerebral blood flow. So this is not a new concept. Everything under the sun has been looked at before, it seems. So at the start of last century, Harvey Cushing did a series of experiments looking at how the cardiovascular system responds to a change in intracranial pressure. So you can see here that as intracranial pressure increases, creating a barrier to cerebral blood flow. So this is overcome by a systemic increase in blood pressure, which perfectly matches this increase in intracranial pressure such that the perfusion pressure is maintained. This became known as Cushing's response and is generally being viewed as a last-ditch pathophysiological mechanism to preserve perfusion to the severely injured brain, for example, after traumatic brain injury or cerebral hemorrhage. So as you can see, that the changes in ICP examined are very high, and I can plot this onto a graph to make it a little bit easier to see. So normal intracranial pressure is between 0 and 10 millimeters of mercury. So Cushing's experiments are really focusing on malignant increases in intracranial pressure recordings, and these were also performed in animals, dogs that were under anesthesia. So it's not a normal physiological setting. So this is some recent work by some of my colleagues here in Auckland, where they've replicated this approach of Cushing, but using more modern tools and a more physiological approach. This has been conducted in the conscious state in a large animal model in sheep. And they've used much smaller changes in ICP. So you can see here increasing ICP by up to around 20 millimeters of mercury. So this is not the malignant intracranial hypertension that Cushing was examining. And what you can see is a very similar pattern in the response. So as the intracranial pressure increases, you get a matching increase in mean arterial pressure such that the cerebral perfusion pressure is maintained. And so this is kind of a validation. And you can see also a tool that Cushing didn't have. Cushing speculated that this reflex was likely to be mediated by the sympathetic nervous system, but he didn't have the tools to be able to prove that. So Rohit and Sarah Jane have shown with direct recordings of sympathetic activity that there's a matching increase in sympathetic discharge. And indeed, in terms of proving causality, they've gone a step further and actually shown that this, by giving ganglionic blockade to effectively turn the light switch off to the sympathetic nervous system and block sympathetic transmission, that you abolish this response. So it's a neurally mediated increase in pressure in response to that change in intracranial pressure. But generally, intracranial pressure isn't normally elevated in most of us. What would happen instead if cerebral blood flow, we're just providing a barrier to blood flow by doing the change in intracranial pressure, but what if instead there was a constriction in the blood vessels supplying the brain? So is there a relationship between cerebral vascular resistance and the level of systemic blood pressure? So if we look to the past, we can look to some really impressive studies carried out in the 1960s by John Dickinson. So he dissected out the cerebral vessels during an autopsy and estimated the vascular resistance by using a saline infusion. You can see this in the photo here. Hoisting up that bag to the ceiling to give a pressure gradient, and then using a cup to collect the perfusate and getting the flow rate from that. Nice simple approach. What did he see? You can see here measuring, he went back to the records and collected the final ante-mortem blood pressure from these patients. And what you can see is that there's a clear correlation between the level of blood pressure immediately before death and the vertebral flow, which reflects that cerebral vascular resistance in those patients. So this is showing that cerebral vascular resistance is proportional to that ante-mortem blood pressure. So I'm sure you're all familiar with schematic figures like this showing the circle of Willis, but you may be surprised to know that half of us have an abnormal cerebral circulation. So we can be missing connections like the posterior or anterior communicating arteries, and this leaves us with an incomplete circle of Willis, or the vertebral arteries can be absent or hyperplastic. So strikingly, having one or more of these variations in the anatomy of your cerebral circulation is a stronger prediction of hypertension than obesity. So given that these variants are for the most part congenital, so you're born with them, this gives some belated support to Dickens' hypothesis about cerebral vascular resistance and the development of hypertension. And as we would predict in hypertensive patients where these variants are more common, we see chronically higher cerebral vascular resistance and lower cerebral blood flow to the brains of these people. So how can we relate some of these ideas to a clinical setting? And I'm going to talk about one of my recent research focuses, which has been on the BP management in ischemic stroke patients. And so we'll talk about this a little bit and move on to that pressure flow relationship in the brain of these patients. So what do the clinical guidelines say about how to manage and target blood pressure during or after stroke? Not a lot, to be honest. So I've looked at the guidelines in a number of different countries around the world. There's all of them express considerable amount of uncertainty. Although the majority of strokes occur against the background of hypertension, at present the clinical guidelines don't discriminate between patients with a history of normotensive or a history of hypertensive in terms of how their BP should be targeted when they're being clinically managed. So with this knowledge gap in mind, we designed a series of studies to characterize the cardiovascular response to ischemic stroke. So to do this, we chronically instrumented rats with telemetry devices to record blood pressure, intracranial pressure, renal sympathetic nerve activity, and as an index of cerebral perfusion, we couldn't do blood flow directly in these chronic experiments, but we've used brain tissue oxygen. And this electrode for this oxygen measurement is placed in the territory where we know we're going to be inducing this ischemic stroke. So we can call that the predicted ischemic penumbra. So after recovery from implantation surgery and a baseline recording period, we induce ischemic stroke via a silicon-tipped nylon suture, which we pop up the common carotid. You can see that the suture in red in the little schematic there. And then on the right side of the slide, we've got some traces of the acute responses. So you can see this is time in hours. You can see shaded in blue the first period of anesthesia. We give the anesthesia as isoflurane and 100% oxygen. So you can see when we induce the animals, obviously they're breathing 100% oxygen, their saturation is going to go up, and indeed we see that. And you can see at the time of stroke, which is marked with the grey dashed line, there's that really abrupt drop in that penumbra oxygen, and that's showing that we're really having a massive drop in blood flow to that area. You can see then there's a period of time, about 2 hours, where the animal is sitting in their home cage having their stroke, and then we need to very briefly re-induce anesthesia in order to reperfuse, so it's a transient occlusion stroke. Again, you can see as we remove the occlusion suture, there's a big surge in penumbra oxygen. That's reflecting that restoration of oxygen, blood kind of flooding into that ischemic territory. So we also performed a series of interventional studies as well. I won't go through them all in detail for brevity, but to briefly summarize in a schematic here, intervening with antihypertensive treatment, and our focus here was to prevent this surge in blood pressure after the stroke, didn't appear to be harmful in either normotensive rats, hypertensive rats, or rats who'd been treated to a normotensive level and then again blocking that. So these results are consistent with many multi-center clinical trials, which largely show that treating purely to prevent post-stroke hypertension is overall neither harmful nor beneficial for cohorts of stroke patients. So as long as you're just keeping the blood pressure to the level it was before the stroke, there doesn't seem to be a problem with controlling the blood pressure. And that's obviously important because, high blood pressure in these patients, in large numbers of patients for this time after stroke, could contribute to some secondary injuries, so secondary stroke, conversion to hemorrhage, etc. So there's a risk involved with having your blood pressure too high, clearly. So there may be some benefits with keeping it lower. But I think one consideration that maybe it's been a bit of an elephant in the room, if you like, is that in the preclinical approach we can be quite subtle about how we do this. We know exactly what the baseline blood pressure is before stroke because we're measuring it. So we're making these long-term telemetry measures. In a clinical stroke cohort, those patients, there's likely to be a disproportionate number of patients who have undiagnosed or poorly controlled hypertension. That's probably a contributing factor to why they had their stroke. So as a thought experiment, what would happen in the real world if we applied a standard fixed blood pressure target to all stroke patients? So what would inevitably happen, and probably does happen, is that in these patients who were, their blood pressure was higher than normal before the stroke, but they didn't know about it, blood pressure, if you're treating to a standard target, if you're treating to normotension, for example, for safety to avoid these secondary injuries, in a subgroup of patients, blood pressure will almost certainly end up being treated to a level below the patient's pre-stroke baseline. So I should emphasize this would be completely inadvertent. In the emergency setting of stroke, you don't have time to call up a GP clinic and check about the patient's medication compliance history, etc. It's just not possible. So the main goal has to be to treat the patient and achieve reperfusion as quickly as possible. But while you're doing that, some decisions need to be made about how to manage blood pressure. So with this in mind, we included an additional group of hypertensive rats where the blood pressure immediately after stroke did exactly this, treated down to a normotensive level. And here you can see the effect of our blood pressure control interventions after stroke on the cerebral perfusion pressure. This is the supply pressure to the brain that we talked about earlier. So each of these time points now is a 24-hour mean. So we're looking over a much longer time period. You can see that in untreated rats, blood pressure increases by about 10 millimeters of mercury, and this is sustained for several days. In treated rats, this is where we've intervened to prevent that response. Blood pressure is clamped close to the pre-stroke baseline level. And in blue, we have these previously hypertensive rats who were treated down to a normotensive level. You can see, as you'd expect, the supply pressure is significantly reduced. So, by around 20 millimeters of mercury or more for a 24-hour period. So that's quite a sizable sustained reduction in the supply pressure. We speculated that over-treating blood pressure in this way may compromise blood flow to the stroke penumbra. And in fact, this was so much the case that our oxygen readings actually became unreliable because the penumbra began to expand and encompassing, we placed the electrodes into the sort of edge of the stroke infarct into the penumbra area, but as that infarct core expand, it mucks up your oxygen recordings a little bit. So we weren't, the readings from those weren't quite as reliable as we would have hoped. So for our outcome measures, we're mostly looking at, and again, we didn't plan a survival study, but what you can see is that we actually had a significant disadvantage for survival for these overtreated rats. And as you'd expect, that was associated with much larger infarct volumes. So we conclude in the setting of ischemic stroke, it appears to be essential to avoid compromising the supply pressure. And this, I just want to point out, this is the case where the blood pressure intervention has only begun after full reperfusion have been achieved. And I think most of us will be in agreement if you imagine that blood pressure control starting earlier during the ongoing stroke time in that hyperacute period, that the consequences may have been even greater. And we're going to explore that specific situation a little bit more soon. But first, I just want to address one of the most commonly misunderstood concepts and how the pressure-flow relationship operates in the brain. So I'm sure that most of this audience will be familiar with the traditional understanding of cerebral autoregulation. So as the supply pressure to the brain increases, that's blood pressure, increases or decreases, the blood vessels supplying the brain rapidly constrict or dilate such that the cerebral blood flow remains constant. So most undergraduate textbooks will have a figure a little bit like this one, which describes the autoregulatory plateau as operating across changes in blood pressure between about 50 and 100 millimeters of mercury. And the implication taken from this is that cerebral autoregulation is powerful and sufficient to protect brain blood flow against all but the most extreme deviations in blood pressure. So, really, do we need to worry about blood pressure at all? So it's important in situations like this, we must understand where the data has come from. So if we go back to this is Lassen's seminal 1959 paper. This is kind of where the concept of autoregulation was really generated. So it's often overlooked that this first study was a meta-analysis of data from different groups of patients or subjects with various pathologies or interventions had altered their resting blood pressure. So autoregulation in this concept is referring to a steady state between individuals and does does not necessarily predict what will happen with dynamic fluctuations in blood pressure within an individual subject. So more recent data from one of my collaborators, Sheikh Sem in Wellington, has shown that inducing blood pressure fluctuations in healthy humans, so this is within subject now, produces a pressure flow relationship more like this, which is steeper. It doesn't have that really extended flat plateau in the middle. So I'm probably preaching to the choir here because we're a basic science, probably largely basic science audience. But this difference between static and dynamic cerebral autoregulation is a really important distinction to make. It's a commonly held view that cerebral autoregulation will help the brain look after itself, whereas in reality, depending on the exact situation and the way in which blood pressure is changing, this may not be the case. And so this concept of the pressure flow relationship in the brain being more of a continuum between cerebral blood flow being really well buffered against long-term fluctuations in blood pressure, but relatively poorly buffered against short-term fluctuations in blood pressure is gaining momentum. And this has been really, if anyone wants to read more about it, it's been really elegantly explored in a couple of very recent reviews, which I've linked to here on this slide. In particular, the misapprehension that cerebral blood flow is protected during dynamic shifts in blood pressure has a particularly long half-life in the clinical arena. And so this is an area where many of us in the field are advocating for increased awareness and understanding. And certainly I hope that the teaching in the medical schools of the upcoming clinical staff is starting to reflect our current understanding a little better. So we've established a novel methodology that lets us study the interactions between pressure and flow during experimentally induced decreases in blood pressure in the conscious rat. So again, everything I do, we're always trying to do this in the conscious state wherever we can. So in a similar approach to what I described earlier, the rats are chronically instrumented with devices that let us measure beat-to-beat arterial pressure via telemetry, and then we use internal carotid blood flow. So in these animals, we also implant a silicon balloon into the abdominal vena cava. This is via the femoral vein. And this balloon, you can see here, it's got a really nice capacity. It's very, very small in diameter at rest, but then we can pop some saline in and blow it up via an intrascapular port. And inflating this balloon lets us trap blood in the hind limb circulation, reducing venous return, inducing a transient fall in blood pressure. So it's a little bit like an internal lower body negative pressure. And you can see a typical example of what this response looks like here. So the occlusion marked in yellow here, you can see a big fall in blood pressure. I'm spoiling the results a little bit, but you can certainly see that fall in cerebral blood pressure, blood flow as the pressure falls. So because we're measuring pressure and flow, just to check against what we saw in those human studies, and you can see that just like in the human patients in Emma Hart's work earlier, that resting cerebral blood flow is significantly lower, and obviously cerebral vascular resistance is significantly higher in hypertensive animals compared to normotensive. So that's nice. We're reflecting the real life human situation quite nicely there. Secondly, so when comparing the pressure flow relationships to this induced fall in blood pressure, the dynamic fall in blood pressure in normotensive and hypertensive rats, you can see that both strains do show a small plateau, but it's not nearly that 50 to 150 plateau that we would expect from that dogmatic textbook view of how cerebral autoregulation works. So cerebral blood flow drops by about 50% of baseline with a 50 millimeter fall in blood pressure. And also worth considering in the hypertensive rats, if you suddenly dropped the blood pressure down to a normotensive level here, again, you'd be causing a significant reduction in cerebral blood flow for the short term at least. We're not doing long-term perturbations to pressure in these studies. So coming back to this hyperacute period around stroke. So this is just reminding you that blood pressure increases immediately. So within seconds of us inducing this middle cerebral artery occlusion. So in terms of the clinical scenario, so how this pans out for patients, the patient would likely have their stroke event would occur at home or out in the community somewhere. That would have to be recognised, and then they'd have to be transported to an A&E. And so the likelihood is that the patients would be presenting to an A sometime during this ongoing stroke period. So as I've mentioned already, the prior knowledge of baseline blood pressure would be extremely rare for the clinicians sort of assessing this patient. Also note that treatment advances such as clot retrieval, which was sort of first demonstrated in about 2015, and is really spreading throughout the clinical practice very widely now. So to undergo endovascular thrombectomy to pull out the blood clot that's causing the stroke, many of these stroke patients will now require some sort of sedation or general anaesthetic in order to undergo this treatment intervention. You can see from our RAT data that inducing anaesthetic in any situation causes a fall in blood pressure, and if you're very observant, you can probably note that when we're inducing our anaesthetic for the second time in these animals to do the reperfusion, that fall in blood pressure, you can see visually it's a little bit higher when we induce GA during an ongoing stroke, which is what is now happening in the clinical setting. So sorry, this is a busy slide, but I'll take you through gently, I hope. So we can see this a little bit more clearly in these results. So now instead of just looking at the group temporal response, we've now zeroed the blood pressure and Penumbra oxygenation to the time of GA induction for each GA. So firstly, we do the induction of GA at baseline in order to give the animals the stroke. Then secondly, we induce GA in order to do the reperfusion. So on the left, we have that temporal response. We're looking at the first 10 minutes after the induction of anaesthesia. And then to the right in the black and white, that's just the group data showing, comparing the delta, so the change in brain tissue oxygen or blood pressure over that, from 0 to 10 minutes. So we can see that even at baseline, hypertensive animals show a bigger fall in blood pressure with anaesthesia. And this is probably not surprising. Their blood pressure is higher, there's further to fall, and it's consistent with the clinical literature. So you can see in our animals that the brain oxygenation with the baseline induction shows a consistent increase in all groups. So this just reflects the way that we give the anaesthesia. We do hyperoxic delivery of anaesthetic. Also, the anaesthetic we're using, isoflurane, is a volatile anaesthetic, and it's suspected or known to have some direct cerebral vasodilatory actions. So basically, the message from this is under normal circumstances, the normotensive and hypertensive brain is quite capable of preserving its own blood supply despite these reductions in blood pressure. So when GA is induced in exactly the same way in the same animals, but during an ongoing large artery occlusion stroke, we see that the magnitude of anaesthetic-related hypertension is significantly greater in hypertensive rats. It's actually pretty similar in the normotensive Wistas, so that doesn't seem to change, but in hypertensive rats, it's greatly exaggerated. And that was the case. It's not just a matter of blood pressure having further to fall, because we also see this bigger response anaesthetizing these animals during stroke in animals where the blood pressure was actually chronically controlled before the stroke. And so the blood pressure in these animals is falling to quite a low level. You can see the hypertension group and the controlled hypertension in red and green is actually falling to a level below what we see in the normotensive rats. And that's really, really striking. So these results indicate that inducing general anaesthetic during an ongoing stroke has likely compromised collateral blood flow to the penumbra. You see, when you're looking at the brain oxygen results there, in the Wistas, we still see a little bit of an increase in the oxygen content of the brain in that penumbra area, but we see certainly no increase, and in fact, there's a small but significant fall in the oxygenation, and that's really powerful evidence that we're getting a collapse of that collateral blood flow, which is all the That's the only thing the ischemic penumbra's got to supply it, because the main supply vessel is occluded. And so this is exacerbating the ischemia in these animals. So if general anaesthesia makes it more likely for blood pressure to be low, what happens to this dynamic pressure-flow relationship under anaesthetics? So we usually try and do all our experiments in conscious, but in this case we're chronically instrumenting the rats and then recording these responses during anaesthesia to understand a bit more about what happens in that situation. So these two slides, we've just used two independent measures of cerebral perfusion in these animals. So on the left, we've made direct measures of absolute blood flow. So that's the internal carotid blood flow that we've used before in the conscious animals. In fact, some of these animals are those conscious animals just anesthetized to do the stroke. On the right, we've used contrast-assisted high-resolution ultrasounds. That is a way of looking at regional perfusion, and we can separate it into the left and right hemispheres, which gives us we haven't yet done this in stroke, but it'll give us an internal control for looking at the area experiencing the stroke versus the area, the other side of the brain that's got presumably normal flow. Again, we've used an abdominal vena cava balloon to induce a transient fall in blood pressure, and the take-home message from this is that there is little or no autoregulation under general anaesthesia. And we've tested that with two commonly used anaesthetic agents, propofol and sevoflurane, and we really don't see much evidence of autoregulation occurring. So again, this is just emphasizing that anesthetizing stroke patients really is likely to require special care, and perhaps that blood pressure might be a simple tool that could be used to prop up cerebral perfusion. So this is all animal data, but surely things will be different in human stroke patients. So reassuringly, the hyperacute stroke clinical teams are much more proactive at managing blood pressure in patients than we are in the lab. We don't usually even look at blood pressure during our surgeries. But we do see this is a trace from Safe Asleep, which is the anaesthetic management system used at Auckland City Hospital across the road. But you do see blood pressure is really surprisingly labile during anaesthesia. So this is a raw record. This is during an endovascular thrombectomy procedure. And you can see this particular patient spends well over half an hour. They've spent about an hour, which is the average duration it takes to get these clots out, with their blood pressure of less than 80 millimeters of mercury. They didn't seem to be hypertensive before, but that's still quite a long way below the baseline level. So what happens across a group of patients? So this is just a relatively small examination of 50 EVT patients where we've retrospectively stratified these patients by their history of hypertension, which we got through either hospital or GP records. And we've then compared the pre-induction blood pressure to the procedural mean. So you can clearly see that standard management, as would be conducted with most surgical procedures, results in a blood pressure below the pre-induction level. So this is in both normotensive and hypertensive stroke patients. So not surprisingly, the difference is much greater in patients with a history of hypertension. And the question is this safe? So at present, blood pressure management during endovascular thrombectomy is generally viewed as being a balance between low, which might risk underperfusion of the penumbra, and high, which risks secondary complications. So protecting collateral blood flow is critical to help salvage the vulnerable tissues in the penumbra. You don't want to be impairing collateral blood flow, but we don't really have a way of assessing collateral blood flow in patients in real time. There's some ways you can do it this sort of qualitatively through looking at the vascular imaging that they do during the stroke procedures, but it's not really practical to make treatment decisions about the patient. And presumably there's some sort of sweet spot for blood pressure. But my question is that likely to be one sweet spot that's going to be the same for all patients, or might this be different in different patients or different patient groups? So we need to consider that any cohort of stroke patients will have a variable mix of baseline blood pressures, but with a skew towards hypertension. So the evidence I've shown you so far suggests that cerebral and collateral perfusion to the penumbra is likely to depend very heavily on blood pressure. I believe this is likely of particular importance in stroke patients compared to other patient groups. And I think it's intuitive that a patient who had severe undiagnosed hypertension or uncontrolled hypertension before their stroke is probably going to do better if their blood pressure was kept higher sort of throughout that hyperacute period. And happily, this question is currently being addressed in a multi-centre RCT called Masterstroke, which is being led by my colleague and collaborator, Doug Campbell, and his team at Auckland City Hospital. And so if you want to read a little bit more, we've just, the protocol for the stroke's just been published in the International Journal of Stroke. So hopefully in about another 12 to 18 months, we'll have a bit more of an answer for this question. So is one size fits all the right approach? So now we're going to move away from the brain a little bit. So let's look at other strategies our bodies can call upon to protect and maintain blood flow. So if the brain can be considered a bit of a greedy consumer organ, to use the supply chain analogy, the venous circulation would be the storage warehouse holding the stock or the blood volume in reserve to accommodate a surge in customer demand. So our veins hold about 60% of our total blood volume at rest, with a significant proportion of this venous blood contained in the mesenteric circulation. And this is the circulation that supplies and surrounds our gastrointestinal tract. So although it's often looked in favour of the higher pressure and brighter colours of the arterial circulation, the veins really do play a vital role in buffering the effective circulating blood volume by accommodating or releasing their stores of blood on demand. So the pressure-flow relationship to organs such as the mesenteric bed, unlike the brain, it's not determined solely by the metabolic needs of the mesentery itself. So, unlike the arteries, the veins are relatively thin-walled with less smooth muscle, and venous pressure is a fraction of what we see in the arterial side of the circulation. So, if you consider the simple schematic of the venous reservoir, you can imagine a pool of blood sitting in the venous circulation, with the flow back to the right atrium determined by the resistance to venous return. So because the veins are highly compliant, it takes a certain amount of blood to just fill the veins or hold them open, and this is termed the unstressed volume. So you can imagine that as sort of the passive reservoir. So any additional blood volume in the venous circulation on top of this unstressed volume will begin to exert a force on the walls of the veins. And so this is considered the stressed volume. So I refer to them as a separate volume. In reality, these two volumes are not physically separated. It's kind of just a thinking tool to help understand how the system works. So to increase the stressed volume, there are two possibilities. So we can either add additional blood volume, so for example via an intravenous infusion, or the veins themselves could squeeze or constrict, and this would place more force on the blood volume within. So you can think of that as the sides of the pool coming in and squeezing up the level of that unstressed volume in the schematic here. So a higher stress volume would increase the pressure gradient and the preload to the heart. So one measure of the level of squeezed in the veins or venous tone is the mean circulatory filling pressure, and we're going to come back to that in the next couple of slides. So there's not a huge body of previous work specifically examining venous circulatory function, but there is some really nice work, and this is a couple here. So it's been suggested that there's an increase in venous pressure and tone in hypertension, and that this increased venous tone is associated with the heightened sympathetic nervous activity that we know is characteristic of hypertension. The mesenteric veins in particular have been studied anatomically, and they show an incredibly dense sympathetic innervation, even more so than the mesenteric arteries, which is maybe not what you expect. You know, we sort of expect that sympathetic effect on tone to largely affect the arterial side, but that may not be the case. So it's been shown that disrupting the sympathetic input, in this case via celiac ganglionectomy, can ameliorate the development of hypertension. But we don't know a whole lot about the dynamic interactions between blood pressure and flows within these venous reservoir beds, especially without the potential confounds of terminal anaesthesia, which is how some of the studies have been conducted. As we've just seen in ischemic stroke, that can dramatically alter the pressure-flow relationship. So to approach these questions, again, we've made recordings in conscious, chronically instrumented rats. And this particular approach is one of the most sophisticated and challenging chronic instrumentations our team have attempted to date. And this was really driven by a really talented postdoctoral fellow in my lab. So these animals, they're implanted with a dual pressure telemeter. So we have pressure catheters in the abdominal aorta and abdominal vena cava to measure arterial and venous pressures. We also have perivascular flow probes around the mesenteric artery and veins. This permits us to record beat-to-beat volumetric flow in and out of the mesenteric circulation. We also have so I can put those in there. We also have a right atrial balloon, so similar to what we saw before for the dynamic cerebral autoregulation studies, but now sitting in the right atrium, and also a venous catheter for intravenous access. Phew. So in terms of the system schematic earlier, we're measuring pressures and flows on both the arterial and venous side of the mesenteric bed. Cool, and I'm just going to show you in the next slide. This is just a video of one of our rats as they've been connected up. So you can see the rat in his cage. The signal's being recorded in real time here. And this first section is when the rat's just resting quietly in his cage. You can see him sitting, not asleep, but he's sort of quiescent. And so before we make all of the recordings I've shown you, we've been very patient and we've connected the animal up, given them. It often takes at least an hour for them to sort of settle down again. And then just before you do your recording, you're just about to do your infusion or your intervention, and suddenly the rat does this, and you can see, the positional effect of that change in body posture on the signals. In particular, you can see that big dip in the blood flow there. That's the mesenteric arterial flow. So now, if that happened, we'd then have to wait with some more patience for the signals to settle down and record a new baseline. So once we're happy, they've recovered from that initial instrumentation surgery, so 10 to 14 days usually recovery. Each rat will undergo sort of a series or a barrage of intervention and tests on different days. And today we're going to look at the results from volume depletion and expansion, with or without concurrent block of the sympathetic nervous system with ganglionic blockade, which we've heard mentioned earlier as well. So mean central filling pressure, this is assessed in our conscious rats using an approach which was refined by Greg Fink and his team at Michigan State. So we inflate that silicon balloon in the right atrium. That basically simulates a temporary cardiac arrest. We stop blood flow going to the heart for about 10 seconds. This allows a redistribution of blood from the arterial to the venous circulation, and you can see a big fall in blood pressure, as you'd expect, because we're basically pausing cardiac output. And you can see at the same time you get an increase in the central venous pressure. So in a living conscious animal, we can't stop the heart for long enough to let the blood reach a complete equilibrium. But there's a technique where we can look at the plateau in this first 10 seconds and apply a correction that lets us calculate the mean central filling pressure. And as a reminder, that's a reflection of the venous tone. What we can see here is that we see a higher mean circulatory filling pressure in our spontaneously hypertensive rats. Again, this is in agreement with the previous literature. And that when we block the sympathetic nervous system, this produces a reduction in the mean central filling pressure in hypertensive, but not really in normotensive rats. And so this is consistent with a chronic elevation in sympathetic venomotor tone. So onto the blood volume changes, and I'll take you fairly gently through the first set of this data and just step you through it. So this is a group of normotensive Wistar rats, or Wistars. Normotension's always blue. We're recording blood pressure, and they're in that sort of setup in the Perspex box that you saw before. Recorded a baseline period, and then we've used an infusion pump, or a withdrawal pump in this case, and we've recorded 20% of their calculated total blood volume over a period of 4 minutes. So you can see this progressive withdrawal is indicated by the arrows at the bottom. And then there's a brief pump off response for a few minutes recorded afterwards. Or in a second experiment, so we did this twice in every animal, the mean central filling pressure was assessed immediately after completing that volume depletion, just so you're getting it before there's any sort of recovery adaptation. And you can see that blood pressure is a bit boring in this. It stays pretty steady despite that sizable depletion. So the body's quite good at coping with this sort of a challenge. So here are the same rats on another day where they've been pre-treated with the ganglionic blocker hexamethonium 5 or 10 minutes before we do this volume withdrawal. And you can see that blockade of the sympathetic nervous system now results in blood pressure beginning to crash starting from about halfway through the withdrawal. So we can now add in our hypertensive rats with baseline and after hexamethonium. And as you can see, we see this crash again, but it seems to begin earlier in the hypertensive rats. So they're maybe not quite as good at coping when you take away one of these props for the modulation of venous flow. They're not quite as good at protecting their blood pressure. Central venous pressure didn't change during the volume reduction. The venous bed often doesn't. It just kind of adapts to whatever volume is in it. And was not different between the different strains of rat, normotension or hypertension, or after the ganglionic blockade. So the mean central filling pressure was reduced by the volume withdrawal, and we believe that rather than that reflecting venous tone per se, because we're changing the volume of the system, this reduction in the NFCP likely reflects a direct effect of the reduction in blood volume. So we're also measuring the arterial flow in and out of the mesenteric bed. So this is the mesenteric arterial flow. You can see that over time, this arterial flow reduces during this progressive volume depletion. And the same is true for mesenteric venous flow. But to make sense of what this means in terms of the fluid shifts within the venous bed, we can actually combine these two simultaneous measures of blood flow in and out of the system to determine what's happening to the net movement of blood. And so that's what's been done here. We've sort of done a real-time calculation over that depletion, and now we're comparing just the net fluid movement at the ends, so that 20% volume withdrawal point. And you can see here, during the volume reduction, there's a net outflow of blood from the mesenteric bed. And the rates, you can see the rate here is about 1 ml per minute. The pump rate, so we do the volume withdrawal is based on the weight of the rat, but because the rats are all of a similar age and weight range, the pump rate is on average around about 1.5 mils per minute. So we're taking the blood out in order to achieve that 20% withdrawal. So this is suggesting that the efflux of blood from the mesenteric bed is buffering the reduction in blood volume. Most of that the blood that's being withdrawn is being buffered by the mesenteric bed. So interestingly, contrary to our hypothesis, the ability of the mesenteric bed to counter that decrease in blood volume, it still persists after ganglionic blockade. So this doesn't seem to be directly mediated by the sympathetic nervous system, or at least in the way that we've assessed it with the ganglionic blockade. So we can now move a little faster through the equivalent results for volume expansion. So you can see here that obviously ganglionic blockade drops the baseline blood pressure in both hypertensive and normotensive rats, but in all cases there's little or no change in mean arterial pressure during this volume expansion challenge. So you can see here the central venous pressure tends to show a small but steady increase over time with volume infusion. That's in both strains of rats and doesn't seem to be altered by ganglionic blockade. Looking at the mean circulatory filling pressure, consistent with what we saw during volume depletion, we now observe that the mean central filling pressure now increases in all groups of volume expansion, again for the same reasons, because we're adding volume to the system. So again, we look at this flow balance during the volume expansion. So in normotensive Wistar rats, you can see a net movement of blood into the mesenteric bed. And as we saw before, the magnitude of this inflow, it's about 1.4 mils per minute. This is almost perfectly matched to the average pump infusion rate. So it seems that the mesenteric bed in Wistar rats is accommodating almost the entire infusion of extra volume. Looks a little bit different in the hypertensive rats. You can see this isn't the case. There's no net shift of blood volume into the mesenteric bed. In fact, if anything, there's a small net outflow of blood. Very unexpected. So we believe that this indicates that the mesenteric bed in hypertensive rats really has a reduced capacity to accommodate increases in blood volume. Ganglionic blockades, if you remember, the ganglionic blockade didn't really seem to have much effect during volume depletion. But it does seem to abolish these differences in the shifts in blood volume, removes the differences between the strains. So the system seems a lot more passive after going without blockade. And this suggests that the sympathetic nervous system is playing a role in mediating these differences in capacitance of the venous, mesenteric venous bed between normal tension and hypertension. So this is just kind of putting all the results up. I'm not going to go through in detail, but to briefly summarize, the mean central filling pressure is higher in hypertension. In Wistar rats, the mesenteric bed accommodates both volume depletion and expansion. But in the SHRs, the mesenteric bed accommodates depletion but not expansion in the normal situation. The sympathetic nervous system appears critical to maintain blood pressure during volume depletion in both Wistars and SHRs, but the sympathetic nervous system doesn't appear to be critical for mesenteric outflow during volume depletion. Our interpretation is that there are potentially different mechanisms and control systems operating and contributing to volume expansion versus depletion responses, and we've got plans to try and explore that in more detail in future studies. And this really brings me to near the end of my talk. So I've shown you some of our work looking at the importance of blood pressure for maintaining brain perfusion in ischemic stroke, how our understanding of the cerebral pressure flow relationship needs to be updated, and how cerebral autoregulation may differ in disease states such as hypertension and under clinically relevant settings such as anaesthesia. And I've also shared some of our recent work where we're trying to characterize the mechanisms regulating the venous reservoir and how this may change in cardiovascular disease. So looking to the future, so a major ambition of ours is to make these type of intricate real-time pressure flow recordings over much longer durations to really let us evaluate causality and changes with disease pathologies over time, and assess the impact of chronic interventions to improve organ blood flow rather than just kind of doing short experiments on the bench for a few hours. But to achieve this, we really need to be able to ditch the cables and tethers. I've put the photo in here just to emphasize, it's not practical to try and make these type of recordings with the wires all connected up. And I believe that we may be hearing a little bit about some innovations on that front in the next few weeks. I'm very excited to hear more about that. So I just finished by acknowledging my team. So a lot of this work was conducted by some really talented postdocs. In particular, Tonya Emons has really been an enthusiastic driver of those mesenteric circulation studies. And another postdoc, Deborah Fong, drove some of the cerebral autoregulation and all the funding bodies. So thank you everyone for your attention. I look forward to some questions.
All right. So the first question that we have here, Fiona, for you is, if flow is so sensitive to pressure, yet metabolically the brain requires constant, precise oxygen delivery, why are vasoregulatory mechanisms not tuned to match supply to demand? He also mentions that this happens very well in skeletal muscle when it's exercising.
Yeah, that's a really great question, and it highlights one of the big differences between the brain and our other soft tissue organisms. So, our skeletal muscle's got the ability, when you put great metabolic demands on it, that it can expand. So it can accommodate more blood flow by the actual organ becoming bigger, and the brain doesn't have that ability because it's encased in our rigid cranium. So we certainly have a very sensitive way of fine-tuning the blood flow within the brain by neurovascular coupling, and that tunes that local blood flow to the metabolic demands. But that restriction in at the whole brain level, which is the level that I'm studying, does make things a little bit more difficult for the brain. There's a limited capacity to expand to accommodate more blood flow, and so I think that's one of the reasons why we see that slightly different relationship within the brain than we do in other organs. It's a good question.
Mm-hmm. Yeah, definitely. Fantastic. Thank you for that question and for the answer, Fiona. The next question here is, it's a long one, so I'll try and read it quickly. The finding that resting cerebral blood flow is lower in hypertensive animals suggests that the selfish brain theory does not restore blood flow to the brain at a time when the heart is challenged to pump out the same amount of cardiac output during a higher afterload. Why then is resistance to the brain higher if it's trying to selfishly maintain its own perfusion?
Yeah, that's another good question. And I think that one's really coming to that chicken and egg question about what's happening first, that change in resistance, or the pressure first and then a change in resistance. And it might be an element of both. But certainly we think there's reasonable evidence in both preclinical models of hypertension, such as the spontaneously hypertensive rat, and also I showed you some of the evidence in human patients that change in cerebral vascular resistance may predate the rise in blood pressure. And so I guess you could view the development of systemic hypertension in that case as being adaptive. So it's trying to compensate and keep cerebral blood flow higher, but it may not be achieving this perfectly, so we still see that decrease in flow. The prediction we could make is that if you force blood pressure down in that setting, that you may actually compromise cerebral blood flow. And there's, again, I didn't go into it today, but there's some evidence in Emma Hart's work where you can see that patients who are being treated for high blood pressure have lower cerebral blood flow than patients who are not yet being treated, sort of recently diagnosed hypertensives. And that may also help explain why blood pressure can be just so difficult to treat. Even if patients are compliant with medication, sometimes it's really hard to get blood pressure down to a normotensive level, and that some element of that resistance may stem from an underperfused brain.
Mm-hmm. Absolutely. That's a very interesting finding, though, something that you wouldn't necessarily expect. Okay, I think just based on time, I'm going to address one last question here. This question is, if arterial blood pressure is dropping, that would create an imbalance between mesenteric inflow and outflow and a net shift of volume out. Is that what is happening such that the sympathetic blockade does not compromise the volume shift out?
Yeah, we're still trying to tease out what's happening there. So that's referring to a situation where we're doing a volume depletion. And so in that setting, we in the normal case, we don't see a drop in blood pressure. And what I think we really need to do to address that question is, and we can do it with our recordings because we've got these really high resolution recordings of pressure and flow simultaneously, is we probably need to do some modeling to try and pick out causality. So is that drop in pressure, is that the driver for a change in flow, or is it happening, the temporal association of those events? And we haven't got an answer for that yet, but I hope that we will.
Mm-hmm. Definitely. Well, I just wanted to thank you, Fiona, for all of your fantastic insights today. It really was a pleasure to have you with us.
Oh, thank you everyone for coming. It's been a pleasure to do.
In closing, thank you so much again for taking part in this Inside Scientific webinar, sponsored by Transonic Systems and produced in partnership with the American Physiological Society, and we look forward to having you with us again soon.